Syndrome Questionnaire. It's a 14-term questionnaire. Again, it goes over symptoms, and it has a diagram with labeling. So the questions ask the patients how to rate the performance of the activities and how it would aggravate their symptoms, or if they would need to modify the activity in order to achieve the desired results. And then after the questionnaire is filled out, there's a diagram that has a head, neck, arm, and hand in it, and it has different keys for you to fill in where the pain is, for you to describe where it is, and label where it is. Next, we have the visual analog scale. This is a 10-centimeter graph. It symbolizes the patient's self-assessment of their pain level. And if we're more to the left side, that means there's less pain. And if we're more to the right side, that means there's more pain. And it's used as a self-reported scale to assess one's pain level for their specific injury. Next. This is my article extraction chart. This has all 9 articles that I used throughout my research study to compare and contrast conservative versus surgical treatment for thoracic outlet syndrome. And then it shows you all the subjects for each research study, the research design type, the Pedro and JBI score, this CEBM rating, and then I included the outcome measures that were used in each article. Now we have the results. So for conservative and upper extremity function, we have 3 articles that are prevalent to this. We have the article by Kim et al. That used the visual analog scale and had a statistically significant p-value, and then the article by Ortak, which used the VAS and the dash, which also had a statistically significant p-score. And then finally, we have the Smith article, which is the outlier, that was written in 1979, which uses the VAS and the dash. The p-score was not labeled there, but how the patient went on about conducting the experiment is explained in the box. There was an 80% improvement in patients initially, and then 75% of the initial 80 stated that they had little to no occurrence in months after they received conservative treatment. But these 3 articles state that conservative treatment leads to better improvement in the upper extremity function and reduction of symptoms based off of these specific outcome measures when when used hand in hand together. Now this is the table for my surgical findings and my upper extremity function. We have 1, 2, 3, 4, 5, 6. We have 6 articles, all using the dash VAS and CBSQ score. Most of the articles had a statistically significant p-value, and then all of the comments explain exactly why the studies were important or what they found. And in the research articles written by these 6 individuals, it states that surgical treatment for thoracic outlet syndrome is the most effective form of treatment to help improve upper extremity function in individuals, and the studies highlight the long-term positive findings of having a cervical intervention like a steroid injection, first rib resection, or a nerve block to help relieve the symptoms consistent with thoracic outlet syndrome. So now we're going to go into the results for question 1. Is an isometric exercise program more effective in reducing numbness and tingling in treating an adult from 20 to 40 with thoracic outlet syndrome compared to no treatment? And the answer is no. Isometric exercise is not effective in reducing symptoms of TOS. Stretching, joint mobs, and KT tape are effective. Question 2, the results. What is the most effective therapeutic exercise program in reducing pain out of a manual therapy, isometric exercise, and active exercise for an individual with thoracic outlet syndrome? Manual therapy in the form of joint mobilization to the first rib, AC, and SC joint is the most effective treatment out of these 3 options. Next, question number 3. Is a PNF focused treatment plan for an adult from 20 to 40 with thoracic outlet syndrome effective in lowering their DASH? No. PNF patterns were found to not be an effective treatment type for thoracic outlet syndrome. Typically, we're going to stay with stretching, joint mobs, and KT tape if we're going the conservative route. And if we're going the surgical route, we're going to most likely see a nerve block, first rib resection, or steroid injection. Next, question 4. Is a purely isometric exercise program more effective in reducing numbness and tingling based on a DASH than only a surgical intervention on patients from 20 to 40 years old with thoracic outlet syndrome? It was found that conservative treatment will improve the patient's DASH score, but surgical treatment will improve the DASH score by an even greater margin. Both were significantly different. So here's an overall summary. Conservative therapy is effective in treating thoracic outlet syndrome using techniques specifically focused on stretching musculature, joint mobilization, and KT taping. Surgical treatment was also found to be more effective in treating TOS than conservative treatment using procedures like nerve blocks, steroid injections, and first rib resections. Now to discuss the limitations of my studies. First, there was a dearth amount of research that has been done on thoracic outlet syndrome. It's something that isn't studied in depth in the field of physical therapy because it's very difficult to diagnose specifically what's going on. Yes, we can understand that it's thoracic outlet syndrome, but it's hard to understand what type of thoracic outlet syndrome is going on, and then where exactly the impingement is occurring, and how we can effectively help to treat it. There's just not a lot of information on it. Next, I had some limitations with finding research within the desired time frame. Initially, ideally, I wanted to keep the research between 2014 and 2024 within that 10-year range so that we could have the most up-to-date research. But due to the dearth amount of research done on TOS from a physical therapy standpoint, it was really, really, really hard to find articles within that given time frame. Next, finding PT-specific articles. Again, like I said, it was super hard. A lot of the stuff on TOS had to deal with like MDs or surgeons, stuff that we do not deal with because it's not within our scope of practice. And then finally, there wasn't a lot of uniformity when it came to the specific treatment types found in a lot of the different studies. Like for the surgical treatment types, when they talked about steroid injections, they talked about different types of steroids across different studies, but there wasn't one common one used. And then for the stretching techniques and the KT tape techniques, a lot of those varied, and there wasn't a uniform way to treat thoracic outlet syndrome. Some of my recommendations for future research. I would like to see more research done on both treatment types to improve reliability and validity of the treatment types. And then I would like to have more specificity in the characteristics of the subjects. And have most of the studies include all individuals with TOS? So, in conclusion, both conservative and surgical treatment types are a great intervention for thoracic outlet syndrome, which is great to know as a physical therapist because when we get a patient who comes in with thoracic outlet syndrome, we know that we can treat them from an acute standpoint. We can help reduce uh, signs and symptoms and return their arm to functional capacity. But based off of a lot of the findings and a lot of the articles, if we want um, long-term improvement, the best treatment, the best form of treatment, is to get a surgical procedure done. So that's where us as physical therapists have to step in and know how to treat within our scope of practice and then know when to refer out if our treatments have come to a stop and are no longer helping improve the overall function or status of the patient. And that is my PowerPoint.